Hi, in today's episode, we're going to talk about, can you take HRT if you've had endometriosis? I'm Dr. Valorie from Progress Your Health.
And I'm Dr. Maki from Progress Your Health. So I know this one sort of, hits home for you. This is from April. We're actually in the month of April. That April and
calling her
would,
April.
Yeah, would be good. Why don't you go ahead and read her question?
So, hi, I'm a 57-year-old woman in perimenopause. My question is it possible for women with endometriosis or endomyosis to do HRT? I started oral progesterone 2 years ago and got as high as 300 milligrams, not a lot of symptom resolution. Switched to a progesterone troche, 50 milligrams, morning and night, and about 3 months ago added in testosterone, 0.25 milligrams, 1 time a day, 5 days a week, and a biased 80-20 ratio, 1 milligram a day, and can go up to 2 milligrams. Everything was good, but now cramping and spotting has returned. I've had heavy bleeding as long as I can remember, and my main complaint is menstrual cramps throughout the month, not just around my period. I do not have any fibroids, but I've had a lot of cysts and polyps over the years. I've had many ultrasounds and transvaginal ultrasounds because of this.
Well, that's a tough one. 57 in perimenopause. That her ovaries are working overtime.
Yeah, her ovaries must be rock stars.
Yeah. That's highly unusual to be just cycling in general when you're 57. But if you would expect there to be sort of a estrogen dominant sort of a situation, maybe you expect it to last longer. Maybe not.
Yeah, I think the reason, you had mentioned that this hits home is I've had endometriosis. I've had stage 4 endometriosis. I've had hyperproliferation. I've had cysts. I've had polyps. So I know what it's like to have your hormones not balanced, to have this happen. But I do believe if you've had endometriosis, yes, you can do HRT. The whole point behind the HRT is to balance it so that it doesn't aggravate. So you think somebody's had endometriosis. They've had a history of polyps or something where they're maybe even other people that have had a history of migraines, menstrual migraines, you have to readjust that hormone replacement because of their personal past history. If somebody has had a history of joint pain or autoimmune, that's the whole thing. But behind HRT is to tailor it for that individual. But I do think if you've had endometriosis, you can take HRT. I will say, just to be perfectly honest, I'm on HRT right now. I do a rhythmic dosing where I cycle my estrogen and progesterone. In fact, I'm probably going to talk about this on our next, we're doing a newsletter, so I'm writing an article where I talk a little bit about how I'm going through menopause as a hormone doctor, yet I also have treated women for 20 years for menopause and hormone imbalance, but it's so much different now that I'm actually going through this transition myself than it was before. I'm so grateful to the women that trusted me even when I wasn't in menopause, but I have a truly kind of a new understanding about menopause now that I'm going through it, and I'm a hormone doctor. So that's probably going to be my next article, because when I started hormone replacement, I was hesitant too because I've had endometriosis in the past. Mm-hmm. My last surgery was in 2010, so it was a long time ago, and I've done a lot, since then and even prior to that. But I was hesitant, thinking, oh, that estradiol is going to make that endometriosis come back, or maybe I'll get another endometrioid cyst, or endometrioid cyst, or maybe I'll get polyps back again. It did go through my mind, and I know the hormones, so I can understand anybody else, being apprehensive, and I have a true, I guess more, I don't know what, empathy or sympathy or something for that, because it does flash through your head.
If you think about it though, if you have a history of endometriosis or fibroids or anything like that, going on rhythmic dosing where you're intentionally recreating the cycle, it sounds, on the surface, it sounds completely counterintuitive. Mm-hmm. Like, why would you do that? Yeah. You shouldn't do that, because you're right, it could exacerbate, but of course, you and I talked about it, we knew your history, we knew where you're coming from. So instead of starting at the normal starting point, because of that history, started a little bit lower, and it's now taken, a good 6 months?
Yeah, about 6 months. And I do it a little differently. I know the whole goal is to recreate the menstrual cycle, like a healthy 28-year-old, female menstrual cycle, Not my original menstrual cycle.
No.
My original menstrual cycle was kind of really skewed with the estrogen this way, and I'm sure my estrone was all over the place, and I had no progesterone. I think it was probably like that since I was a teenager.
Sure, yeah.
So it's not recreating my original menstrual cycle. It's recreating a healthy, balanced one.
Yeah.
So I will say here I am on month 6. I have worked my way up. When you do the rhythmic dosing, you still individualize the dosing to that particular person. So now I've kind of worked, I'm still on a lower rhythmic dosing dose, but I've gone up quite a bit, and I feel really good. I get a period on day 27. It's not like it used to be super heavy, run to the bathroom every 45 minutes. It's just like 3 days long. It starts right away, not just a bunch of spotting for a bunch of days. And then it's when it's done, it's done. So it's so I wish I had had periods like that when I was young, especially in high school, in college.
That's where when you're this case is about the endometriosis, but using rhythmic dosing as a backdrop of that, or explaining, because you're right, on the surface, no, you wouldn't want to do that because you're going to recreate all the problems of the endometriosis. But that, in reality, that's not really the case. It doesn't usually pan out that way. What about, let's say, more conventional forms? What about a woman like this, putting her on the patch?
I think I would be more hesitant with the patch, because the estradiol patch, I always say, even though it says, 0.025 milligrams or 0.05 milligrams, it sounds like a low dose when you're looking at those milligram numbers, but it isn't. I do find that the estradiol patch can be pretty strong, and that women that are sensitive to estrogen, which would be those of us that have had polyps and cysts and endometriosis and our hyperproliferation of the uterine lining with the heavy bleeding like April's having here, I do feel over time, like we're seeing with her, it would exacerbate the tissue. It would exacerbate the tissue, and there would be some sort of consequence that you would have to readjust for. And not that the estradiol patch is bad. In fact, I think it's really great to be able, that women can now have access to hormone replacement, like, estradiol patches from your big box pharmacy, progesterone from your big box pharmacy. It wasn't even like that 10 years ago, or it was very hush-hush. Now, women are advocating for themselves, so I'm glad that they have the opportunity to have HRT. But if you have, if you can, go a route where you can have a practitioner really tailor your HRT for you, that's really the way to go. If you have that,
Sure.
if you can do that. But I would say, for April, that we would want to be a little more specific with her because of her past endometriosis, the polyps and the cysts.
Yeah, and it sounds like even at 57, she's just beginning that transition into menopause. So being gentle with it is one approach, just because of her history. But that's why, like I said, using you as an example in that case, the rhythmic dosing seems like completely the wrong thing to do. But for you, it actually is working out fairly well.
Yeah, the beauty behind rhythmic dosing is you're changing the doses so that your estrogen does go up, but then it comes down. Your progesterone's low, and then it comes up, and then it comes down, just like in a natural cycle, where when you're doing the continuous, static dosing, it's just you're doing the same dose. You're just blasting the body with the same dose every single day. That, I do think sometimes you need to have a little finesse with that. Now, I have lots of patients on static dosing. I based my original practice on static dosing back in 2004. They do really well. I mean, static dosing can transform someone's life. It's just, like I said, having that sort of caveat to know your patient and how you're going to finesse that and tailor their protocol. I will say for April, because of her history of the endometriosis, the polyps, the cysts, the thickened uterine lining, the heavy bleeding, she does need more progesterone. That's just one thing oral progesterone does, is it helps thin the lining of the uterus, which can be magic on heavy periods. So I do feel like her doing the 50 milligrams twice a day. I wouldn't do the morning one, just because sometimes, progesterone in the morning can make you a little tired or a little groggy, but I would definitely go a little higher at night. I would go higher than 100 milligrams for her. I know she said she had 300 milligrams in the past. It didn't really help with her symptoms, but, that was a different time. That might have, that was, who knows when that was 5 years ago or 10 years ago. But I do feel like that progesterone is probably a little bit on the low end.
Yeah, and once a woman goes into menopause, usually those types of things, fibroids and endometriosis, usually kind of becomes dormant anyways most of the time, does it not?
It does, but I have had only one I can think of past 20 years is where it did stimulate some of her old fibroids. She had some old dormant fibroids from the past, and they were stimulated from doing a static dosing of the Biest.
Interesting.
And we had to be, it was one thing where she was on a certain dose, and I had to sort of like tug of war with her, like, okay, if we're going to do the static dosing, we have to do it this way, where she wanted more hormones because you think about that balancing of the symptoms. Sure, you don't want to aggravate your fibroids and have spotting because that's not healthy, but you also really like the way your brain feels when you have that estrogen in it. Yeah. So it's like finding this dance that's going to be safe and at the same time also help with some of those symptoms.
Yeah. Those kind of situations come up all the time. They like how they feel in one respect, but then something else. So you're trying to balance that out. And figure out as the practitioner, figuring out what is the best option for that particular person. Because I mean, I'm preaching to the choir, but there is not one size fits all when it comes to hormone replacement. It is different for every single woman, because everyone has a history. Everyone has like in this case, she's got a extensive history of endometriosis. She's 57, still cycling. I mean, you don't see that very often. That's unusual.
I probably would with April, probably would do the rhythmic dosing with her. I think if you did a low dose rhythmic dosing for her, because it looks like she's just coming right out of perimenopause, going into menopause. There's like this gray area where you're not really in perimenopause, but you're not quite fully in menopause. You're kind of in that limbo land. Mm-hmm. That is a really nice time to introduce the rhythmic dosing, because it's almost like your body didn't forget that it was cycling. Like you just kind of give it what it really needs and get the dosing right, as opposed to, let's say she hadn't cycled for 10 years. Like, my last period was when I was 47. You wouldn't jump into the rhythmic dosing that fast, because their body wouldn't remember, like, it's been a while since I've done this. You really have to sort of work your way into that.
That's essentially what you did. You went from pretty much a little bit of static dosing as you were finishing perimenopause, and then that arbitrary line of where you kind of crossed over, you went right into the rhythmic dosing.
Yeah, I did. Because I was a little hesitant, even though I've been doing rhythmic dosing with women since, 2009, but I've done static dosing the whole time since 2004. And even I was hesitant to start the hormones. I mean, I love my progesterone. I had been taking that for years, but it was that, oh my gosh, I didn't like having that endometrioid cyst that we had to have removed. And the periods, it was, my periods did get better, in perimenopause, just because, I've been doing the progesterone and some different things and lifestyle and supplements. There's so many things you can do, but there was that little nag in thought of, rhythmic dosing, that estradiol what's that going to be like? But, and also too, at the same time, when you're doing rhythmic dosing and you have a uterus, you're going to get a period. And I liked not having a period.
I'm sure, yeah. Nice. Honestly, that right there is the biggest determining factor whether women would even consider rhythmic dosing or not, is the fact that she's going to get a period. Mm-hmm. The fact that you get a period on rhythmic dosing is the part that makes it safe, right? So by raising up those dosages and you're getting the rise and fall, the rationale behind rhythmic dosing, and at least in this respect anyways, is that it creates sort of an anti-inflammatory response. You really prop up the hormones on day 12. That rise and fall creates this sort of a quote-unquote anti-inflammatory environment. You're recreating the way it's normally supposed to be, so you're not recreating the dysfunction of what someone's menstrual history was in the past. So it should actually create some relief, or at least not recreate the problems later on. So like I said, it seems so counterintuitive, but in some ways, like I said, if she went on the patch, 0.05 milligrams, she raised her blood level to 75 to 125 with this history. She's cruising for disaster.
Which it kind of looks like here, even though the 80-20 biased 1 milligram or 2 milligrams is not a lot of hormones there. No. So she's probably
very conservative.
Still making a little bit, but like she said, everything was good, but now the cramping and the spotting have returned. So her pain has returned, her spotting has returned. Like I said, I do think the progesterone troche, so a troche is something you put in the inside of your cheek, and it's supposed to dissolve and be more like a sublingual. I think that it's that right there, just a sublingual progesterone or even a progesterone transdermal cream that you put on would be too low for her. Where I think really, just like, doing an oral progesterone capsule at night and doing a little bit of a higher dose, that right there, I think would help kind of alleviate some issues there. That's what my experience. Same with the cramping and the spotting. She may need to even just stop that estrogen for the Biest for a little bit, just till that spotting goes away. Probably do another transvaginal ultrasound, see her gynecologist, and then the testosterone level she's doing is really low. That testosterone dose is low, but testosterone can aromatize to estrogen. So anytime you're a female's taking testosterone, you got to think it can aromatize and turn into estradiol.
Yeah. Those are, I can see where the trepidation would be, because you think that more estrogen is going to cause problems, so you'd want to use a low dose. But that's why, and that one was interesting, because your case isn't exactly the same, but that history is very similar. And so far for you haven't had any. It hasn't gotten worse. And we've done that with patients in the past as well too. So we sort of know that you weren't the first one that we experimented on, right? We know that.
I am my own experiment. I do that all the time.
Of course.
I try everything.
But on the surface, it seems like, hey, that's a no-go zone. But in reality, it ends up getting a better result on the back end. So that is a tough spot to be. That has come up, quite a few times over the years, and women asking that question. Honestly, I don't know what a gynecologist would say. You'd have to be very careful.
And I agree. Anybody with that past history, it's about, like I said, earlier in the podcast, is, really, working with them, tailoring, like her dose would probably be different than the person next to her, or a bunch of other women. They would all be on different doses, because we're all different. So we're trying to, and she didn't go into a lot of, I'm having hot flashes, or I like the hormones for my bones, or I want it for my brain, kind of going back to what are her symptoms and what is she looking to get out of using HRT for.
Sure. Yeah. Well, certainly she doesn't want any cramping or any bleeding. I'm sure, that's one thing she doesn't want. That's why she's asking the question, because, which is really interesting from where we started, back in the early 2000s to now, the opinion about hormones it's completely took a 360 or 180 difference of opinion of, they're dangerous, don't do them, to now you need them for your bones, your brain, and your heart, right? It's like just a complete 180, which is nice, right?
It's so nice. I remember patients would go see they'd come in, they'd cry, they'd cry at my desk and say, they want to put me on benzodiazepines, or my doctor says I should see a therapist. I've had patients come in, and I know you have too, where couples come in because, the other significant other, the male partner, is kind of, what's going on? What do these hormones mean? It's really nice to see that, that people are talking about it, that we're advocating for it, and also too, like I said, that there are more availability for women to be able to have access to this kind of care.
Menopausal women are complicated. These situations are not, you don't just get to give them a pill and send them on their way. That's what everybody wants to do.
I know.
Everybody wants to give them a pill so they just go away. But these are very complicated cases. But when you get it right, everything changes. That's the best part. Both for the reward you get as a practitioner, but also seeing them, sort of reestablish or resume or change their quality of life in a positive way. I mean. We've known that for a long time. We're sort of, been to the party for a long time, because we've seen those types of changes, in women. But it's just nice now to see that it's getting so much exposure. Maybe just because the group of women there, that this affects, they're sort of like a force to be reckoned with. Like they're going to find the answers one way or the other. So I think it's good. I think it's a good question to ask. But our answer is a little bit, counterintuitive than what you would think.
Yeah, but it's a yes, but it has to be tailored for that person. If you've had endometriosis, it has to be tailored for that.
And that doesn't mean that anyone with endometriosis, that rhythmic dosing is the way to do it, because for everyone that it works for and they're able to achieve what they want, you'd have 2 more behind that or 5 more behind that it would actually potentially exacerbate. So sometimes you just don't know. But most of the time, you're creating that sort of anti-inflammatory environment, which in a situation like that is exactly what you want.
Yeah, because that's what endometriosis is. You have that whole pelvic microbiome with the inflammatory markers. That's part of that endometriosis. It is, but I do have lots of endometriosis, or they've had in the past, endometriosis on static dosing. There's everybody's different when it comes to this. But you were saying something interesting. You're right. Once you get it right, people feel amazing. Like it's a true transformation. But at the same time, once you get it right, you might have to change it, right? Because bodies change, life changes, things change. That's the one thing about hormone replacement. It's always an evolving process. That's why, when you're working with your practitioner, you're going to, do some blood work. You're going to follow up. You're going to say, oh, we might want to change this. I've got, something else has changed. I want to, I've had patients where I met somebody and now our goals are working on libido and, different things. And I've had other people, I did a bone density and my bone density is really bad. And I'm okay, that's what we need to work on. So everybody has their own personal goals. So it would be interesting. I know.
And those goals do change over time as well.
They do.
So there's like this, your starting point and then it evolves over time. So of course, dosing is going to reflect those different stages, and as the goals change, then the dosing is going to change as a result.
Yeah, that's why I'm sure April, we changed her name, but you'll recognize your question. So I would love for you to comment back to us and say, these are the reasons why I want to do HRT.
Yeah, right.
Whether it's for the brain or the bones or whatnot.
Yeah. So if you're watching us, you should be on YouTube. The comments down below, certainly. Ask your questions there if you feel comfortable. You can go to our website. Ask the Doctor is just a simple form to fill out, and we love seeing all the detail that everyone puts in there. It takes time, and but we do enjoy answering the questions because we know as practitioners have been doing this for a long time, these answers are extremely hard to find, which is why we started the podcast in the first place. So keep the questions coming. We'll keep answering them. Any final words for April?
No, I appreciate this. Like I said, I think I might actually write a little bit about this in my own personal experience in our newsletter.
Yeah. So until next time, I'm Dr. Maki.
I'm Dr. Valorie.
Take care. Bye-bye.